Bismillah ar-Rahman ar-Rahim. Good evening, everybody. Thank you for having me today. This is the end of the colorectal session for your day, and apparently it's the end of your review course. It's the scope of my interest talking about bowel management programs, so thank you very much for inviting me to do so. Next slide, please. In order to understand the principle of BMP, it's so important to know the basic anatomy and physiology of the anorectal area. Can you move to the next slide? In the coming slide, we'll talk extensively about the details of the anatomy and the physiology and how to manage patients that present to you after surgery with complaint of constipation and fecal incontinence. At the end of my presentation, we'll talk about rectal prolapse. So let's get started with the anatomy and physiology. For the anatomy, it's very important to know the three important elements in fecal continence. Number one, it's paramount to have an intact sphincter mechanism. Number two is to have a normal colonic motility. And number three is to have a normal sensation for stool and gas. We'll talk about each element in detail. Talking about the first element, which are the sphincter mechanism, we are talking about a group of voluntary muscles which includes the external anal sphincter, the muscle complex, and part of the levator ani. Those muscles, they are normally surrounding the rectum and the anus, and they are considered fundamental component for control and continence. Next slide. This picture will illustrate the anatomy of the anus and the rectum. We'll start from the lumen, from the middle of the screen, where you can see the opening of the anus and the rectal wall, followed by a group of longitudinal muscles, which are, circular muscles, which are the group of the internal sphincter. It's very important to understand what is the importance and the role of the internal sphincter in continence. As you know, internal anal sphincter muscles, they are circular muscles. They are a group of smooth muscles supplied by autonomic nervous system, mainly by sympathetic. They are not voluntary, but they have importance resting tone that play a role in continence, mainly when you talk about the level of gas or liquid stool. These muscles, all the time, they are tonic in a contract status. The resting tone plays a role around 30 to 50% of the continence. So, but they are not a part of the sphincter mechanism as they are involuntary muscles. The next group of muscles, which are the external anal sphincters, those are a group of three muscles: subcutaneous, superficial, and deep group of muscles. Those kind of muscles, they are longitudinal, skeletal muscle. They are supplied by somatic, the pudendal nerve, arising from the S2, 3, and 4. They are voluntary, so they contract and play around 70% of the continence, and mainly talking about the formed kind of stool. The third muscle, which is the puborectalis, which is a part of the levator ani forming the pelvic floor, and this part of the muscle is paramount and fundamental in the continence. So when we talk about continence or the sphincter mechanism, we'll talk about external anal sphincter, puborectalis, and the muscle complex. To explain what is muscle complex is the conjunction of the levator ani to the parasagittal fibers that you can see in the subcutaneous tissue when you open the parasagittal incision. The confluences of this group of muscle form the muscle complex. It comes along the wall of the rectum and the anus. Next slide, please. The second element is the colon motility. In the normal status, the rectosigmoid remains quiet for 24 to 48 hours. This time is necessary for the accumulation of the stool, and then when we have the stimulation of the rectum with distension and peristalsis wave will start, it's completely empty the rectum, and then it remains quiet. It's very important to understand this anatomy and physiology. Like we know very well, the normal pattern of going into the emptying the rectum is every 24 to 48 hours. And that piece of information, we deal with it when we do bowel management programs. Let's say, if we are dealing with a colon which is not moving quite well, very slow or stagnant, we call them hypomotile type of colon, and that might cause constipation. The other group of patients who are the opposite, they have a very rapid transit time and they move very fast and constantly they pass stool, and we label label them as hypermotile colon, especially those groups who had their rectum or sigmoid has been removed and they have no reservoir. Some cases we do face, especially in Hirschsprung, or they have total colectomy for other reasons. They have an ilioanal anastomosis. Those kind of patients, they don't have their colon, they don't have the reservoir of rectosigmoid, and that plays a very difficult group of patients when we deal in bowel management, because they have constantly passing a stool, no reservoir and no colon motility, which means their intestine is really having a rapid transit time. Next slide. So in order to understand your patient and to classify them, are they hypomotile or hypermotile kind of colon, we do a contrast enema. On the left of the screen, you can see a contrast passing through a very dilated rectum and sigmoid. It's a focal dilatation there where you can say it's a stagnant. You can see filling defects, which is full of stool. Those are hypomotile colon. The other picture on the right of the screen, you can see a contrast passing through a longitudinal, a very stretched rectum and left side of the colon. It straight down goes to the pelvis, as you see. Those we know very well. Their colon is really narrow, hypermotile. Whatever stool is there, it will pass right away, will not stay, even the contrast. So the first thing is how to classify your patient is through a contrast enema, knowing their kind of motility, hypo or hypermotile. Next slide. The third element is the sensation. It's a very sophisticated kind of sensation we have at the anorectal area. As we know, the perianal skin is supplied by the somatic nerves, and they are sensitive to touch, pain, and temperature. The more interesting is the rectoanal area. They do have sensation, but a different kind of sensation. They have sensation to fullness when they are stretched. They have sensation of urge to defecate and when to defecate, and they have the urge of the maximum volume of stool they can't tolerate. Those are runs by the parasympathetic nerve fibers coming from S2, 3, and 4. And this kind of sensation is very sensitive as well to the consistency of the stool. It's very different when we are dealing with gas or mucus or liquid kind of stool. Certain nerves sense that, and compared to the semiform to solid stool. Next slide. Moving to the physiology of defecation, we call it sacral arc, and it is triggered, as you know, by the stretching of the rectum by the coming stool. Signals, as you see in the pictures, starting from the rectal wall, there are stretch receptors in green. Signals will be processed to the sacrum, the spinal cord. Those are sensory nerve fibers that sense the stretching, and accordingly a cascade of signals controlled by the cerebral cortex from the top to know the exact and the suitable time and the right time when and to defecate. Signals will go down in the blue arrows. It goes down through the pudendal nerves that cause voluntary movements of the muscles. What will happen is relaxation of the external anal sphincter and a consequence of relaxation of the internal anal sphincter in order to open the anus and allow the propagation of the stool from the rectum out for the process of defecation. And this is what we call in the anal manometry the RARE, which is stand for a rectoanal inhibitory reflex. Shortly, it's distension of the rectum that causes relaxation of the internal and external anal sphincter to allow defecation, and this is a normal physiology. And from there, we can understand the pathophysiology when we deal with constipated or fecal incontinent patient. Next slide. So this is the different causes of pathologies that cause fecal incontinence. Any disturbance in the cascade that we have mentioned in the physiology will cause incontinence, starting from any disturbances in the bowel, resection or injuries, to the anorectal dysfunction, anal sphincter weakness or damage, reduced compliance of the rectum, increase or decreased sensation of the rectal area, changes in the anal and squeezing resting tones, pressure, weakness in the pelvic floor, or even the high up cortical awareness or cognitive function. Next slide. So what is bowel management, and when bowel management is indicated? We have a long list of pathologies that we can treat or bowel management can be offered in order to manage them. In colorectal, especially in pediatric, I do select what kind of patients to treat. In our center, we do select patients with anorectal malformation and Hirschsprung, and sometimes we extend it to patients with idiopathic refractory constipation when they fail medical therapy by our GI colleague. The rest of the patients, like spina bifida, meningomyelocele, sacral agenesis, usually our colleagues from urology, they deal with them. Bowel management also indicated in patients with pelvic trauma, pelvic tumors, whom they have colostomy, and you can give them some hope to revise that stoma and put them back with a good quality of life. Bowel management can be offered as well in different kinds of colon motility disorder. Next slide, please. So what is bowel management? Bowel management program is different programs and regimens that we offer the patients. In the coming slide, we'll talk about these regimens in details, but it's very important to know the principles that I'll highlight it here in this slide. The first principle is to distinguish between the true fecal incontinence and pseudo-incontinence. The next principle is you need to understand their colon. What is the characteristic of their colon? Are you dealing with dilated or a non-dilated colon based on a contrast enema, as I showed you earlier? The third component is after the two pieces of information that you have, you can decide the treatment strategy. And this should be a program run over a 1 week in order to finalize the proper program. Throughout this week, you do daily assessment of the patient in terms of reports, and I'll show you what we do ask, what question we do ask those patients, and daily x-rays in form of a simple KOB. And at the end of this week, or let's say throughout the week, you modify daily the regimen, and hopefully by the end of the week you finalize the regimen and get into a successful program that is keep them clean in the underwear for the coming 24 hours without any accidents. Next slide. So this is in general, and I'll talk in specific in each group I see in our specialized clinic. The first group is the anorectal malformation group. How we do bowel management for those patients. So first of all, children with ARM, they suffer from different degrees of lacking the development of the sphincter muscles and therefore incapacity to hold the stool. It's very important to understand those kids who was born with imperfect anus, they have some kind of deficiencies or underdevelopment of the muscles and the nerves in that area as well. The more complex the defect, the less developed the muscles. The surgeon, by that, can predict in advance who are the kids who will do fine and who had the poor prognosis, and we'll talk about these factors. Next slide, please. So in order to predict continence, some factors you need to highlight and to know them in order to label your patients and choose what's the right program for them. The first factor is what type of defect you have dealing with. Second is what is the status of the cord and the sacrum. Number 3 is what surgical repair has been done. Whether you are the surgeon or the patient has been referred to you from other institutions, it's very important to either to have the surgical report or the operative report, or at least if you can get into the preoperative studies that has been done. For example, if they had a distal lupogram, at least it will give you a heads up what kind of anomaly they had. Number 2, in order to know the status of the spine and the sacrum, you order sacrum x-ray, AP and lateral view. You order spine MRI to see if they are tethered or not. And the last but not least is to do an examination under anesthesia. What information you can have during the examination under anesthesia is the location of the anus. Are they located within the center of the muscle complex by the use of the penile stimulator? And number 2, if there is any anal stenosis, by doing anal calibration using Hager dilators, and see how's the rectum. Is it full or empty from stool? So those are the 3 important information in examination under anesthesia. One more imaging is the MRI pelvis, and we'll talk about it in the coming slides. Next, please. So sacral ratio. This is one of those factors to know the bowel control prognosis of your patient. So simply you order a sacrum X-ray, AP and lateral view, and we do prefer the lateral view for accuracy. And you do the calculation of the ratio by dividing those lines from BC over AB. Those lines drawn 3 horizontal lines. You draw the first line, which is A, between the 2 iliac crests. The second line, which is B, between the lowest point of the sacroiliac joints, and the line C is the tip of the coccyx. So it's the same landmark in the AP and the lateral view. Your calculation, if let's say the normal range that determine a good prognosis with a good continence, if the ratio is equal or more than 0.7. If you have a calculation of less than 0.4, that means this is a very poor prognosis and your patient most likely towards the incontinent group. In between is undetermined, which means that they might swing between more constipated or more toward fecal incontinence when you study them. So again, sacral ratio is one element of predicting the continence, and it's a very good element to know your patient. Next slide. MRI pelvis. It's a very interesting modification done by Dr. Pena and his colleague, Dr. Patel, his radiologist. Instead of just doing a plain MRI pelvis, they do insert a catheter through the anus or the new anus in order to eyeball exactly the rectal lumen in relation to the muscle sphincter. So on the left of the screen, you can see a normal located anus within the center of the sphincter. However, on the right side of the screen, you can see the rectal tube posteriorly located to the asterisk. The asterisk mark I put, it's where the muscle complex is. So basically this patient has an abnormal, or let's say mislocated rectum with an incorrect surgical repair. And this will give an impression that this patient might have fecal incontinence because of mislocated rectum. Next, please. In Cincinnati, the colorectal center has identified a group of patients who had poor prognosis and compared to good prognosis. So let's start with the poor prognosis elements or group on the right side table. Those patients who had an abnormal sacrum or even absent sacrum, who had a flat perineum with poor muscles, and have those types of anorectal malformations like rectal bladder neck fistula, or high or long common channel cloacas, or complex cloacal malformation. We anticipate those patients under the category of poor prognosis with fecal incontinence. The other group, which are the opposite, who had normal sacrum, a normal perineum, good muscles there, good anal cleft and midline groove, and they have those type of anomalies, the rectal atresia, vestibular or perineal fistula, no fistula, short common cloacas, and the less complex malformations. We know that they have good prognosis and more toward constipation. Next table is an interesting one as well. It divides patients into 3 groups, as I highlight them in colors. The group in blue, they are the good prognosis group, patient who had perineal fistula, anal stenosis, vestibular fistula, bulbar fistula, anorectal without fistula, and short common channel cloacas, less than 3 centimeters. Those patients, they do very well. They are having voluntary bowel movements in 80 to 100%, and they might present to your clinic with constipation, and it's easy to manage with the bowel management programs. From this group, I highlighted these patients who are having no fistula. They can come as male or female, and very interesting, this group, they are more toward the good prognosis, and they suffer from mainly constipation that is easy to treat. So keep it in your mind. The other group, I highlight them in red. Those group are the poor prognosis group, and we know that they will come with fecal incontinence and they don't have voluntary bowel movements. Look at the soiling line. They have 80 to 100% degree of soiling. Those are the long channel cloacas, more than 3 centimeters, or those with bladder neck fistula. And the group I highlight in the yellow, this is very interesting one, the prosthetic fistula. Prosthetic fistula, they are in the middle between both group. They are 50%. They can present with constipation, and probably they are more higher toward soiling, which is 70%, and they might come with fecal incontinence. And I can tell you from my experience, they are the most difficult group to deal with in bowel management. Next page, next slide. Now we'll talk how to evaluate patient who had ARM and coming to you for bowel management program. Next slide. So this slide will summarize what we do in our clinic. So we'll start with the middle scheme. We have those patients, let's say from the beginning, to evaluate them, we take a history and we examine them. We order some imaging, including sacral X-ray, spine X-ray, spine MRI, contrast enema, and then we categorize them. Those patients who are candidate for a bowel management, we know that they have a normal, close to normal anatomy, which I mean like the repair is good. There is no poor prognosis group. They have no sacrum or abnormal sacrum. They have a poor sphincter, and their type of anomaly indicate they have a poor prognosis. So in order to help this group, we get them in, we know that they have fecal incontinence, and we can help them by bowel management program, and we offer them from the beginning saline enema. If the saline enema succeeded for the long term, we offered them Malone, which is the continent appendicostomy, in order to maintain the privacy of the patient when they reach the adolescent age group. The saline enema, if it's unsuccessful, those patients, they are candidate for permanent colostomy in order to improve their quality of life. On contrary, the other group who are having good sphincter, good sacrum, and they have a type of defect that is good prognosis, and their surgery was done very well, and either they come to you as frank constipation, or they present with you with soiling, which is pseudo incontinence. Those group, we start the regimen of laxatives. Interesting in this group, they might need a high dose of laxatives. These laxatives is out of the calculation of weight, out of the calculation of height, out of the calculation of the manufacturer recommendation, out of the calculation even of the pharmacist. So they might reach a higher dose in order to help them get a voluntary bowel movements. And if they succeed, we'll continue on those laxatives. We might offer them down the road sigmoid resection. If they have this huge dilated rectum or sigmoid and they can't tolerate anymore the high dose of medications, it causes nausea or vomiting. So we might offer this kind of surgery, and we'll talk in details about it in the coming slides. Let's say the laxatives did not help and we were unsuccessful at that time, we switched them and upgrade them to the saline enema group and to achieve proper bowel movements. The third group, which are on the left of the screen, those are patients who are candidate for reoperation. When you are having a patient with normal sacrum, good sphincters, and the type of the defect should have a good prognosis, but unfortunately they underwent a surgery that mislocated their new anus, we can offer them a redo pull-through, and they have to be assessed after the redo if they need a bowel management or not. Next slide. The second group I see or select in my clinic is the Hirschsprung group. The Hirschsprung patients, after they having their pull-through, they have their line of managements with the primary surgeon. But some group and we do expect in those patients, they have a normal anus, they have a normal sphincter mechanism, and they should do very well from the continence perspective. They are 100% continent. But whom we see in our patients, some of those who are having constipation that reach 5 to 10%, and they are not manageable by the primary surgeon, they send them to our clinic. Or the unfortunate group who are having fecal incontinence, and those have the unfortunate complication of either complete or partial damage of their anal sphincter, or for somehow overstretching of the anus during the pull-through procedure. How to evaluate those patients? For the bowel management, we have to know the type of surgical repair done, and we initiate the evaluation with a contrast enema, evaluating the colon motility, evaluating the previous procedure, and then we do an examination under anesthesia, and mainly to assess the integrity of the anal canal. What does that mean? When we do the EUA, in Hirschsprung, we don't need to use the penile stimulator. Their anus should be normally located within the muscle complex. This is their anatomy. This is their normal. So we do assess in the EUA is the site of the surgery, the site of the anastomosis. How is the dentate line? How intact is the dentate line? Any breach of that line, whether complete circumferential breach or partial. So that will help in their bowel management program. Next slide. The third group we see is the patient with idiopathic constipations. As I said, not all idiopathic constipation I do treat in my clinic. We know very well this is the most common colon dysmotility that we can face. We have to ensure that they are idiopathic. There's no underlying medical or etiology, and they have been through multiple regimens by our colleagues, pediatrician or gastroenterologists, and they are refractory. They are intractable to their therapy. They have a normal anal canal. We know that they have a normal sphincter mechanism, but unfortunate, because of the vicious cycle of having chronic constipation, they have a very dilated colon, dilated rectum and sigmoid, and they do have slow motility. They do have stagnation, and persistently they have constipation. So in order to define what is constipation for those patients, they don't have voluntary bowel movements for days. Our definition of constipation, if it is more than 24 hours, this is considered constipation. Number two, they can have daily bowel motion, but with very hard stool, small amount, and with straining. This is considered constipation. Those patients with soiling, persistent soiling, and when we do an x-ray, you can see fecal impaction. We consider them constipated, and they have as well voiding dysfunction symptoms, urinary symptoms. How we do evaluate those patients? Simply, we do a KOB and we do a contrast enema. It's very important to know this like many patients has been referred to our clinic to rule out Hirschsprung disease. So just by doing a KOB and contrast enema and taking a full proper history, you can tell they are not Hirschsprung. Doing a contrast enema and seeing that the rectum and sigmoid is hugely dilated, filling the pelvis, this is by sure, it's not a Hirschsprung. In my school, we don't do liberal biopsy for those patients. The reason is you will get into the dilemma of many of motility disorders, classifications, different pathology interpretations that will not get you into a diagnosis. And the patient need a management, not a diagnosis. So I don't do biopsy for those patients. Next page, next slide. So after knowing that, how we manage them. So the first group, when I'm dealing with constipation, which are the pseudo-incontinent group, how to manage them? You have to be aggressive, very aggressive. The first, you do your management in 2 lines. The first line is the cleansing. I do offer them 3 days of aggressive cleansing and sometimes to the extent of manual fecal disimpaction. But we do the regimen of 3 days of cleansing with 3 enemas per day. The 3 enemas are, the first enema is saline enema in the morning, and saline enema plus phosphate fleet enema in the mid of the day, and saline enema with glycerine at the end of the day. Sometimes we have the Castile and other additives in addition to the glycerine, but I couldn't find it here, so I don't use it. I use just the glycerine. Once you cleanse them, after 3 days, you start them the maintenance therapy. The maintenance therapy is based on the use of laxatives, and the kind of laxative we do prefer in such patients are the stimulant laxatives, which are the Senna-based laxatives. We know these patients have a hypomotile colon that needs stimulation in order to provoke a voluntary bowel motion. So Senna, we found it the best option from all laxatives that help such patients. What is the dose of the Senna? It depends. Throughout the week of the program, we do adjust the dose, and at the end of the week, we can tell the proper dose that depends on the reporting and the x-ray. If the patient report that they have daily voluntary bowel motion and they are clean, no accident, no soiling, and their x-ray is clean, that's it, the dose that is needed. The other element of the regimen is the diet. Diet, we do advise to avoid whatever cause constipation in their diets. The earlier the management, the more proactive and persistent you are in treating them, you can get them out of constipation. But they have to understand, once they stop the medication, everything will recur. Those medications will help them in 24-hour basis, not more than that. The concern of addiction or being dependent on those medications should be addressed with the family, and they should understand it's not. The long-term use of Senna is safe. Very mild side effect has been seen. And they have to be reassured that this is a gentle medications on their kidneys and liver. In case of failure, we can upgrade or switch them to the Saline Enema group. The Saline Enema in this group is a combination of saline and additives. We usually start with a very high volume of saline and a high concentration of additives, which I mean when we use saline 500 to 1000 ml in a single session. Additives, we use the glycerine that start from 5 to 30 ml. And you can upgrade throughout the week till you clean them up. Most of my patients, they do respond very well to the Saline Enema if they fail medication. And the important thing is the compliance. They have to do it daily in order to have proactive voluntary bowel movements. And the last resort is the colostomy in order to improve the quality of life. Next slide. The surgical options that we can offer to constipation. We do offer Malun. That's the best option for the Saline Enema, or even cecostomy. Those kind of procedures, there are many procedures, and which indicate that none of them are perfect. It's last resort that we can offer to certain type of patients that they have problem with compliance. They have, let's say, as you see in the image, they have a focal dilated rectosigmoid. We can just resect that dilated non-functional part of the colon and do the anastomosis, hoping that might get them out of the medication. So what is the outcome of such procedures? We found that 10 to 30% of patients, they can get out of the medication, but the rest of the patient, either we can reduce the dose or nothing will change. The dose will remain the same. Those procedures not out of complications, so we don't really offer them. And even with Dr. Pena, we don't go through these surgical options that often. Some surgeons, they offer just sigmoidectomy. Others, they do rectosigmoidectomy with a different level of rectum to be removed. Others, they do even more extensive kind of surgeries of removing the whole colon if it is hugely dilated. And honestly, we do not much recommend such procedures. How about the true fecal incontinence group? What is the bowel management program we can offer? It consists of 3 elements. We start from the simplest one. We start with the diet, and then if it's not working, we add medication, and if it's not working, we do the Saline Enema. And from my experience, the best to manage those patients is the combination of all what I mentioned. The diet is a very strict diet, constipating diet, and it should have certain timing, 3 main meals and no snacks. And the idea behind it is to anticipate the time of activating the colon. As we know, the gastrocolic reflex plays a role in the bowel motion. So once we control the time of the meal, we do anticipate the emptying of the rectum. The medication we use is under the category of the slow down colon motility group of medicines. We have the option of using loperamide and the option of using the pectin. Loperamide, it can come in liquid or capsule of a 2 milligram. We can upgrade the dose from once, twice to 3 times a day. We prefer to give it either bedtime or pre-meal. The pectin comes in a powder or a liquid, and we can take it with each meal. Then if If it's not helping, we can do the saline enema. The opposite to the first group, the saline enema should be a very small volume with a low concentration. The volume of saline that we are using range between 200 to 450 ml, and the concentration is 5 to 10 ml of glycerine. Those group is challenging group and it's not easy to manage. So if you failed, we have the option of colostomy, but again, it's a last resort. We'll keep trying with them till we get them into a good quality of life. Next slide. When to start bowel management program? The timing is very important when you are dealing with constipation. The ARM group, once you operate on them, once you close the stoma, if they are from the constipation group, they do come to you early. So as long as they present with symptoms, start them with laxatives. The other group, in contrary, the fecal incontinence, we can't label a child with fecal incontinence until the age of 3, which is the age of toilet train. So we do ask the mother to train them for urine, to train them for stool. And then if she failed and we know what type of anomaly, at that time, we label them as true fecal incontinent group, and we start the bowel management program with saline enema. For the second question is the diet restriction in whether in the constipation or the fecal incontinence group. Yes, diet plays a very important role in their bowel management. And as a child, we know that they have the desire to eat and explore. And what we do in the program is in the first week of the program, when we as a clinician try to find the proper regimen, we insist on a strict diet. And then once we got the right regimen, the weeks after, we advise the mom to introduce item by item, which means like mother should experiment each thing by itself and to see, does it affect the regimen or it does not. So if it is affecting the regimen, causing accidents or soiling, we ask the mother to eliminate this kind of diet and not to give it unless she knows it will cause an accident. So there's no social commitments, she's at home and she can give it to the child. But if she experiments any kind of items and it turns to be okay and the program is running nicely and the child is clean, so she just labeled this in the green list and she can continue with that. The other two questions, for how long we continue on BMP and what's next and what else in the coming slides. So what is the long-term outcome? Honestly, BMP, it's a very dynamic program. And I do see my patients for long. Family should understand this treatment is for life because we know we are dealing with anomalies. We are not correcting the anomaly and their defect surgically. So this part should be treated medically. And on the long term, there's some adjustment can be done for the regimen, either to downgrade it or upgrade it. Either sometime we offer them to hold the program completely and they can know the results within 24 hours. These options can be given to the family and they can do it. And they can decide what is the quality of the patients, not us as a physician. So it's the parents to decide how clean they want the child for their school performance, for their self-esteem, and so on. So it's an ongoing dynamic program. We can go up and down. We can switch the programs if they are on, let's say, on enemas and they don't want anymore to have the enemas. We can try laxatives. We can give them again another chance of a program for 1 week, for we call it laxative trial, and we see if we succeed, we can stop the enema completely. And if we did not, unfortunately, we can ask the mom to go back to the enemas and we can try later. These trials can be done once yearly or twice yearly, and some cases showed success. And I guess, and we do understand that this happens because of the development of the child, they understand what is the social cleaning means. So they do become more compliant on laxatives rather than when they are younger. The other thing we can offer if they succeeded on saline enemas is the balloon and cecostomy. And this is one of the machines that I found it very attractive to the adolescent, the pristine. They can use it probably it's easier and to use and more friendly for them, so they like it. Though the balloon, it's more accessible for them and giving them privacy, but this is an option I do offer them. The other two options, if we decided on colostomy as a last resort, we do offer bowel management through the stomach. So instead of, what I mean by that, they do the same regimen of saline enema that they have been using instead from the anus. They do it from the stomach, and they do use saline, they do use additives like glycerin, and in order to minimize the changing of the bag or problems with the bag. And this is, I do it mainly for the cloaca extrophy. Next patient. So I'm proud to present our group. This is the group of my nurses that they do deal with my patients. In our institutions, we had an experience for the last 5 years now. We have been doing bowel management program, and we opened our clinic in 2017. We have 2 clinics. We do run colorectal clinic where we select patients for bowel management. We don't see all patients, however, most of the patients can be managed by the primary surgeon, and those who are difficult or non-compliant, they send it to our clinic. We have the cloaca clinic, which is a multidisciplinary team clinic. We do see cloaca and cloaca extrophy in combination with our colleagues from the urology, neurosurgery, and gynecology, and we address their needs. Since the last year, we are working on a group of nurses to be our colorectal nurses and therapists. And I'll take the chance to thank one of our trainees, Dr. Arwa Mahfouz, that she helped us a lot in preparing the educational material and the illustration and the videos for our program. Next slide. So I'll share with you some of our experience. Next slide. So we have seen since 2017, can we go back? Since 2017, we have been seeing patients and the number is increasing. Next slide. We do see ARM boys, girls, cloaca extrophy, Hirschsprung, and recently we are in collaboration with the adult colorectal surgeon to see adult patients as well, whether they are transitioned from the pediatric clinics or they are new for us and coming after neonatal surgeries for Hirschsprung and anorectal malformation. Next slide. So this is the forms I was talking about when you want to do, this is the enema group. Throughout the week, I see my patient on Sundays, and I see them the next Sunday, and in between we have daily reporting and daily x-ray. The report for the enema group is the amount of the saline, that the volume and the duration of the saline enema, which I mean is the saline enema should be slow, should be given over 10-15 minutes. And if they have any, we are using a balloon catheter, large balloon, 24 with 3 ways, which has a 30 ml balloon. So the balloon is to prevent leak and get the benefit of all the materials we are using. The daily adjustment of the glycerin for the concentration, and if there is Castile to use, if fleet is needed or not. And then the mother report for us 3 questions, which are the bowel motion at the time of the enema. So after removing the balloon, the child should stay on toilet for 45 minutes, and the mother should report describing the amount of stooling and the nature and consistency. Then in the coming 24 hours, he should report how many voluntary bowel motion he had and the description of each and the time of each, and is it related to the meal or not, and if there is any accidents. And if so, they have to report the description and the time. The next slide. The other group, which are the laxative group, again, it's a program of a 1 week from Sunday to Sunday. I do see them on Sunday clinic, and then during the week, I receive the reports and the x-rays. For the laxative group, we determine the laxative amount and if they use fiber or not, or they are using fleet or not. And the questions the mother should answer is if they have a voluntary bowel motion, the time and the description and the amount, as well as the accidents, if they have or not. Next slide. So I selected some patients to present. Those are patients who has been through bowel management program. We'll start with the first group is the anorectal malformation girls. We have those with perineal, vestibular, and no fistula. All of them, they come with constipation and they are managed with laxatives. Only one I had in this group, which is vestibular, and she presented with fecal incontinence and managed with enemas, with loperamide, and this is because of her sacrum. She's having abnormal sacrum, which is hemisacrum, and still she's booked for an MRI to look at the status of her spine. So it's very interesting that she had a low anomaly that is good prognosis, but unfortunate because of status of her sacrum. She's fecal incontinence and in the enema group. The next group is the ARM boys. We have stenosis, perineal, bulbar, prosthetic, and bladder neck. As you can see, the higher the anomaly, you can see them coming with fecal incontinence. The stenosis and the perineal and most of the bulbar, they are constipated and managed with laxatives. I have 2 patients in the bulbar group with fecal incontinence and they are in enemas. One of them is non-compliant to laxatives and that's why we switched them to enema. And one of them, he has a very hypermotile colon that I could not manage him with laxatives and he needed enemas. Let's talk about the bladder neck. I have 1 patient with fecal incontinence and he is having, in addition to his high anomaly, he had sacral anomaly and spine anomaly. So that's why they are managed very well with the enemas. The prosthetic group, as I said, it's a very interesting group of patients. So I have the majority, they present to me with fecal incontinence and they are very difficult. I manage them with enemas plus diet and plus loperamide, and their response is really variable. So some of them, they do have sacral anomaly and spine anomaly, but they do well with laxatives, and the others, they are not, and we have to continue in the enemas. This group, I offer them every now and then, switching to laxative, and again, their response is variable. Some they do well with laxatives, and the others, they are not. But I keep trying with them with switching the program from enema to laxative once or twice a year. The same group of ARM who are boys but unknown, which means they have been operated in other hospitals and they could not provide me with a report. I tried to understand them from the presentation. Are they constipated or fecal incontinence, and manage them accordingly. But once I have them with tethered cord or sacral anomaly, I need to manage them. They present with fecal incontinence and I manage them with enemas. And 2 of them, they have Malone. Unfortunately, the majority of those patients, they have mislocated anus from the primary surgery. This is a very interesting group in the discussion with the family, that they do very well with the enemas, but the family wants more than that. They can ask for a redo procedure, especially when they have a normal sacrum and a normal spine. And would they offer, we can offer them redo, but not to hope for a proper or a better prognosis. So still I'm debating the redo procedure on them. One of them has been already discussed with Dr. Pena, and his suggestion is to continue on the enemas and not to do a redo procedure. And the other one is under discussion at those days. But still, we can offer them the switch to a laxatives and try if they don't want to have a Malone and they still looking for a redo surgery. We should understand as a surgeon, redo surgery is not as easy as we talk. You are dealing already with an area that has been touched before, fibrotic, the muscles might not have that strong contraction and you might damage it. You have to have the stimulator during the redo, but still, if you don't have contractions, you might not do better than the first surgery. So sometimes sticking on bowel management is better than the redo procedure. The other group is can you go back to the table? The Hirschsprung. Hirschsprung, we don't see them. The majority come with constipation. They can manage with laxatives. Some, they do not do well, not compliant to laxative. We offer them enemas. They like cecostomy cecostomy. One of them have it. And we give the enema through the cecostomy tube. Unfortunately, I had one patient with true sphincter damage and extensive excoriations and with true fecal incontinence, and very difficult patient, and we tried to help them with enemas, loperamide, and diet, but still. Cloaca, we have those with short cloaca. Again, despite it's a short cloaca, I have this patient with fecal incontinence and required enema because of the tethered cord. Next patient, next slide. So what else we can offer? Those are new, not new, but I don't have them in my institutions, but it's good to talk about them to open the options for the family to seek different. They might have different outcome. They have the hope. We can offer them. Some centers, they do offer local injection of bulking agents like Solista. Solista is not FDA approved for pediatric, but recently in Cincinnati, in the state, they have been using it with submucosal injection. They select patients for that. It's acting as a filler for those patients who had fecal incontinence and a patulous anus. So they said with the report, it might help the patients, though it's temporary, like they need to repeat the injection every 3 months, but they can offer some sort of help. The second option is the sacral neuromodulation. It's a very interesting way of therapy. It's an old one since the 90s and has been started first by our urology colleague. What they do is they stimulate the sacrum through introducing electrodes, as you see in the picture, whether under interventional radiology or the surgeon. Under X-ray, they do introduce electrodes, unilateral or bilateral, into the sacral foramina. They do it in 2 stages. The first stage is to test the results, and you can, in 1 to 2 weeks, they can decide if this patient is getting any benefit or not. And then the second stage, they introduce the pacemaker or the battery and the implanted subcutaneously. Our urology colleague, they found it very helpful for the continence, urge incontinence in the adult population. And in Cincinnati, in the last 3 years, they start to offer it for our patients with constipation and fecal incontinence. Initially, they were insisting that the sacrum has to be normal with normal anatomy, but considering our population, we're dealing with abnormal sacrum, they start to implement it in those having anomalies. And they found some results. Anyway, it's a trial. You have a testing window. If it's helpful, you can do the permanent implant, and that will help the child. And they found it very helpful in the group that you want to switch them from the enema to the laxatives. They see some improvements, and you can then switch patients, stop enemas, and start those laxatives. Third option in the market now is our GI colleague, especially the neuro gastroenterologist. They start to do manometry for the colon and the intestine. And from their interpretation of their reports, they said we can tailor therapy. They do it on patients mainly with idiopathic constipation, and they do divide them into 3 categories. Those with normal transit time, second group with a slow transit time, that they think those kind of patients, they might be responding to surgical therapy, as I mentioned, rectosigmoidectomy or sigmoidectomy. And the third group that they have evacuation disorder, and this group will benefit from medication or even using saline enema and Melor. The other group that they are getting benefit from manometry, interestingly, is the Hirschsprung group post pull-through. Again, they categorize them into a group that they have normal propagation. Those group, they present with fecal incontinence, and they think they will be benefit from loperamide and anticholinergic medication. The second group, who present with constipation and no propagation activity or even absent propagation activity, they think they are candidate for surgical resection. The third group, who have a very hypertensive anal sphincter and present with constipation, and they subject them for Botox injection. And the fourth group, who have normal study, normal propagation, and normal anal sphincters, and the fear of defecation. So they present with constipation and soiling, and behavior therapy is helpful for them. Last not least, I didn't write it, but worth to mention it, is tissue engineering. People are working now in regenerating the internal anal sphincter smooth muscles, and they succeeded in preparing a segment of colon that had some peristalsis, but till the moment it's still under the research, and probably we can hear something in the near future about these innovative regenerative medicine. Next slide. This is in the adult literature, but I would like to widen your scope that people have been trying since ever to do sphincter reconstruction, whether they do primary repair of the sphincter, they do other muscle grafts using the gracilis muscle or the gluteus muscle. They invent the artificial bowel sphincters. All of these actually, it's not, I wouldn't say not applicable in the pediatric population, but they have a high failure rate and a high mortality even in the adult literature. So in conclusion, bowel management is an artificial way to keep patients who have fecal incontinence clean. It consists of finding by trial and error the program that cleans the colon, keep the patient clean in the underwear on a 24-hour basis. Probably I'll stop here to take your questions, and then I have a single slide with rectal prolapse. What do you think?
Can you go for the rectal prolapse, so then we'll receive the question?
Sure. So can I have the last slide, please? So rectal prolapse, basically it's symptoms. It's not a disease. You have to know what is the underlying cause of this rectal prolapse. Is the patient having constipation, or the other way, diarrhea? Are they from cystic fibrosis patient or inflammatory bowel disease? All of these under the pathophysiology of weakness of the pelvic floor, secondary to malnutrition or dehydration. And you can see some group of the anorectal malformation who had rectal prolapse after the anoplasty as well. It's important to know the degree of the rectal prolapse. Is it a mild or severe? What does that mean? Is it partial or complete? The whole circumferential mucosa is prolapsing. To which degree, like 1 centimeter or more? What do they present with? Is it ulceration, bleeding? It should be a painless protrusion. Some they do present with incontinence because of the weakness and the overstretching of the pelvic floor with the complete prolapse of the rectum. In the pediatric population, we do see them, especially if they have cystic fibrosis and if they have anorectal surgeries. Rectal prolapse, do we need to treat all rectal prolapse? The answer is not really. We can offer them non-operative management by addressing the underlying condition and treat it, whether it's a constipation or a dehydration, and it will resolve spontaneously. Can we offer surgery? Yes. In case of anorectal malformation, if they are bothering the child, causing extensive mucus discharge and bleeding and ulcerations, and it's circumferentially prolapsing and more than 1 centimeter, we can do as simple as a trimming of the mucosa and resuturing the anoplasty area. We can offer injection. For the other group of patients, we can use different sclerosant agents like saline, deflux, glucose, sodium urate that can be helpful, whether temporary or permanent. Surgical options are many. We can do as simple as fixation, rectopexy, whether abdominal approach, open or laparoscopic, and we have the perineal approach. And the other option is to do the resection of the rectosigmoid or the rectal mucosal area transanally. So this is for rectal prolapse. Thank you so much.
Thank you, Dr. Jamila. Question about what is the recommended dose for laxative, and is it safe to use it less than 2 years old baby?
Okay, it's a very important question. Let's be specific. Senna, you are talking about Senna. This is what we use in our bowel management program. Senna, it's not, let's say, FDA approved for those less than 2 years of age. Okay, so unfortunate, I can't use the Senna in this age group. I do use lactulose, though it's not the best option, and I do have problem with the lactulose, but I try to push them till the age of 2, and then I switch to Senna. For the dose of the Senna, as I said, it's out of the manufacturer recommendation. So what we do is, whether you are using a syrup or using a tablets. Let's start with the tablets. Tablets comes, in our institution, it comes 12 milligram in a tablet, okay? So the younger age group, let's say less than 5 of age, I do use half tablets, and then I can start from a half tablet, which is 6 milligram, and increase it. The older age group, which are the adolescent, 8, 9, or 10, I do use a full tablet, 12 milligram, and I take it from there, okay? For the Senna Liquid, it comes by ml. We start with a 6 milligram as well, which is equal to 6 milligram, which is equal to 4 ml. So I start with the 4 ml and I go up and down, depends on what the response of the patient. This is for the liquid, I use it for the age less than 5. More than 5, I switch them to tablets.
Great. Doctor, can you tell us the difference between the true and pseudo incontinence?
Okay. Thank you for asking this question. So let's say it again. This is the first step in your bowel management, is to classify your patient. So in order to say this patient is constipated and having pseudo incontinence, those patient is having clinically, symptoms wise, they are not passing bowel motion regularly, or they have accidents, very small, hard bowel motion. And when you do an X-ray, you can see that the rectum and the left side of the colon is loaded with stool. And if you order a contrast enema, you can look at a very dilated rectum and sigmoid. So those are the constipated pseudo-incontinence group. So what happens is they impact the rectum with stool. They are not evacuating. It becomes a hard stool, and what they are passing is, or soiling, is the liquid fresh stool that come across or in between the hard stool. The other group, which is the true fecal incontinent group, when you take a history, they will tell you that they are frequently passing bowel motion, which is soft. They are frequently having accident. They are unable to hold their stool. And when you do an X-ray, their colon is empty. There is no fecal loading. And when you do a contrast enema, you can see narrow rectum, empty rectum, and narrow. So that's the difference.
Okay, great. We have received a plenty of questions, but due to time limit, we have to stop here. Thank you, Dr. Jamila. We always heard about you in the field of pediatric surgery, and we are lucky to hear from you today.
I'm happy to have you to be with you today as well. And the rest of the question, you can send it to my email. I'm happy to answer them in person. And I hope I simplified bowel management, and try your best to have the chance to get into my clinic and look at how we do this programs, and wish you all the best.